What that means practically is this. A person with OCD who is treated as though they have generalized anxiety disorder will not only fail to improve, they may get significantly worse. The most well-meaning cognitive behavioral interventions for anxiety, when applied to OCD without modification, can deepen the very cycles they are attempting to interrupt. The reassurance that helps an anxious person momentarily regulate becomes, in OCD, fuel for the compulsive cycle. The avoidance that offers temporary relief from anxiety maintains OCD in a way that has no parallel in standard anxiety treatment. This is not a small distinction. For many people, it represents years, sometimes decades, of the wrong treatment, the wrong framework, and the accumulated suffering of a condition that was never properly named. Today we are building a precise, clinically grounded, practically useful map of these two conditions, where they overlap, where they diverge, and what the difference means for understanding and treatment. A Venn diagram worksheet that maps this comparison visually is linked in the description. Let's start from the ground up. Section 1. Defining the landscape. To understand the relationship between OCD and anxiety, we need precise definitions, not the colloquial versions that dominate popular culture, but the clinical ones. Anxiety, at its core, is the mind and body's anticipatory response to perceived threat. It is the alarm system activating in response to something that feels dangerous, whether the danger is real, imagined, future, or ambiguous. At adaptive levels, anxiety is functional. It sharpens attention, mobilizes resources, and prepares the organism to respond. At clinical levels, the alarm becomes dysregulated, too sensitive, too persistent, or triggered by stimuli that do not warrant the response it generates. Anxiety disorders, generalized anxiety disorder, social anxiety disorder, panic disorder, specific phobias, share this common architecture of excessive, dysregulated fear responses that cause significant distress and functional impairment. The content of the anxiety varies by disorder. The underlying mechanism, threat perception activating the alarm system to a degree disproportionate to the actual danger, is shared. OCD, obsessive-compulsive disorder, was classified as an anxiety disorder in the DSM until 2013, when it was moved into its own category, obsessive-compulsive and related disorders. That reclassification was not administrative. It reflected a growing research consensus that OCD, while it involves anxiety as a component, is driven by a distinct mechanism that is not captured by the anxiety disorder framework, and that this distinct mechanism has direct implications for how OCD should be treated. OCD is defined by two core features, obsessions and compulsions. Obsessions are unwanted, intrusive thoughts, images, or urges that are experienced as ego-dystonic, meaning they feel foreign to the person's sense of self, contrary to their values, and deeply distressing precisely because they are unwanted. Compulsions are repetitive behaviors or mental acts performed in response to obsessions, with the goal of reducing the distress the obsession produces or preventing a feared outcome. And it is the relationship between these two features, the obsession-compulsion cycle, that makes OCD distinct from anxiety and that determines everything about how it should be treated. Section 2. The overlap. What OCD and anxiety share. Before we map the differences, which are consequential, it is worth being precise about the genuine overlap, because the overlap is real and it is part of why the diagnostic confusion is so persistent. Both OCD and anxiety disorders involve the activation of the threat response system. Both produce significant subjective distress. Both can result in avoidance behaviors. Both frequently involve the prefrontal cortex, the brain's threat evaluation and decision-making center, and the amygdala, the brain's alarm center, in dysregulated patterns of activation. Neuroimaging studies of both populations show elevated activation in the cortico-striato-thalamo-cortical circuits, the loops that connect the thinking brain to the emotional and motor response systems. Both conditions involve intrusive thoughts. This is clinically important. The presence of intrusive thoughts does not distinguish OCD from anxiety. Intrusive thoughts, unwanted, distressing mental content that seems to arrive uninvited, are present across the anxiety spectrum. The question is not whether intrusive thoughts are present. The question is what the person does with them, and what the thoughts are doing to the person. Both conditions are maintained by avoidance. This is the core insight from behavioral theory that applies across the anxiety spectrum and into OCD. The behaviors people use to manage their distress, avoidance, escape, safety behaviors, provide short-term relief and long-term maintenance of the problem. Whether the problem is a phobia, generalized worry, panic, or OCD, the behavioral mechanism of distress reduction strengthening the very pattern it is attempting to escape is consistent. And both conditions respond, at least partially, to cognitive behavioral approaches. CBT has substantial evidence across the anxiety disorders and is a component of the most effective treatment for OCD. The overlap in treatment approach is part of why the distinction can feel less urgent than it actually is. But, and this is the critical point, the specific CBT technique that is most effective differs substantially between standard anxiety disorders and OCD. And it differs in a direction that has direct clinical consequences. Section 3, where they diverge, the obsession-compulsion engine. Here is where the map splits. And here is where precision becomes essential. The defining feature of OCD that separates it from anxiety disorders is the obsession-compulsion cycle, a self-reinforcing loop that has a specific structure and a specific logic that anxiety, even at its most severe, does not replicate. It begins with an obsession, an intrusive thought, image, or urge that the person finds deeply distressing and entirely unwanted. The content of OCD obsessions is remarkably consistent across populations and cultures: harm obsessions, contamination obsessions, symmetry and order obsessions, religious or moral scrupulosity obsessions, sexual or relationship obsessions. And in every case, the obsession is ego-dystonic. It feels alien to who the person is. The person with harm OCD who has intrusive thoughts about hurting someone they love is not a violent person suppressing violent impulses. They are a person whose mind is generating content that violates everything they care about, which is precisely why it produces such distress. This ego-dystonic quality is one of the most important distinguishing features. In anxiety, the feared content is generally continuous with the person's concerns. Someone with health anxiety worries about illness because health matters to them. Someone with social anxiety fears judgment in contexts where belonging matters to them. The anxiety is about something that the person genuinely cares about. In OCD, the obsessive content is specifically, reliably about the things the person finds most abhorrent. The devoted parent has intrusive thoughts about harming their child. The deeply religious person has blasphemous intrusions. The gentle, non-violent person has violent images. OCD attacks the person's deepest values. Anxiety threatens the person's genuine concerns. That is a meaningful distinction. The compulsion is the response to the obsession, and this is where the cycle becomes self-perpetuating. The compulsion might be behavioral: checking, washing, ordering, confessing, seeking reassurance. Or it might be mental: reviewing, neutralizing, mentally undoing, praying, counting. The compulsion temporarily reduces the distress of the obsession. And that temporary relief is the mechanism by which the cycle is maintained, because the relief teaches the brain that the compulsion works, which makes the compulsion more likely to be deployed the next time the obsession appears, which means the obsession never gets the chance to not be responded to, which means the brain never learns that the obsession is not actually dangerous. Compare this to generalized anxiety disorder, where the core feature is worry, a verbal, cognitive process of mentally rehearsing threat scenarios and attempting to problem-solve them. Worry and obsession can look similar on the surface, both involve repetitive, distressing mental content. But worry is generally about realistic, if unlikely, threats in the external world: finances, health, relationships, the future. And worry is ego-syntonic. It feels like the person, like their genuine concern for things they care about. The person with GAD knows they are a warrior and experiences the worry as an extension of themselves, even an exhausting one. The person with OCD experiences their obsessions as intrusions, as something being done to them by a mind that has gone wrong. Section 4. The role of avoidance versus compulsion. Both conditions involve behavioral responses to distress that maintain the problem. But the specific nature of those responses, and the implications for treatment, differ in ways that matter enormously. In anxiety disorders, the primary maintaining behavior is avoidance. The person with a phobia avoids the feared object. The person with social anxiety avoids the social situation. The person with panic disorder avoids the contexts associated with panic. And the gold standard behavioral treatment, exposure and response prevention, which we'll discuss in the next section, works by having the person approach the feared stimulus without escape, allowing the anxiety to habituate naturally. The logic is, face it, stay with it, discover that you can tolerate it and that the predicted catastrophe does not materialize. In OCD, avoidance is present but it is not the primary maintaining behavior. The primary maintaining behavior is the compulsion, the specific, ritualized response to the obsession that provides relief. And this distinction changes the treatment target entirely. In anxiety treatment, we are interrupting avoidance. In OCD treatment, we are interrupting the compulsion, which is a fundamentally different behavioral target requiring a fundamentally different clinical approach. There is also a particularly important clinical distinction around reassurance-seeking. In anxiety, providing temporary reassurance can be a compassionate bridge. It is not ideal as a long-term strategy, but it does not structurally worsen the condition. In OCD, reassurance-seeking is a compulsion. Providing reassurance to a person with OCD, telling them that the feared harm will not happen, that their hands are clean, that they are not a bad person, provides the same temporary relief and long-term maintenance as any other compulsion. Well-meaning reassurance from family members, friends, and even therapists who do not recognize this mechanism is one of the most common ways OCD is inadvertently sustained by the people who most want to help. Section 5. Why the wrong treatment makes things worse. This section is the one that has the most direct clinical urgency, and the one that most directly explains why the OCD versus anxiety distinction is not merely academic. The standard cognitive behavioral approach to anxiety involves two primary components: cognitive restructuring, examining and challenging the thoughts that maintain anxiety, and exposure, approaching the feared stimulus to allow habituation and disconfirmation of the feared outcome. Both of these approaches, applied to anxiety disorders, have strong empirical support. Both, applied to OCD without modification, range from insufficient to actively counterproductive. Cognitive restructuring, the practice of examining a thought and finding evidence for and against it, generating a more balanced alternative, is a powerful tool for anxiety. For OCD, it is a trap. When a person with OCD engages in cognitive restructuring of their obsessive thoughts, analyzing whether the feared harm is actually likely, generating counter-evidence, reasoning their way to safety, they are performing a mental compulsion. The analytical engagement with the obsession is the compulsion. It provides temporary relief. It reinforces the obsession-compulsion cycle. And it teaches the brain that the obsession required a response, which is precisely the opposite of what OCD treatment needs to accomplish. Standard exposure without the response prevention component is similarly insufficient. Exposure to the feared stimulus in OCD does reduce anxiety temporarily, but if the compulsion is then performed, the lesson the brain learns is, the stimulus was dangerous, the compulsion was necessary, the pattern is validated. The response prevention, the deliberate, supported withholding of the compulsive response while the obsessional distress is present, is not an optional add-on to exposure in OCD treatment. It is the mechanism of change. Without it, exposure alone does not interrupt the cycle. This is the clinical heart of why misidentification matters so much. A thoughtful, well-trained therapist who misidentifies OCD as an anxiety disorder will apply empirically supported anxiety treatments in good faith and watch their client fail to improve, or worsen. The client will conclude that therapy does not work for them, or that they are too severe, or that something is fundamentally unfixable about their experience. They may spend years in this loop. Getting the diagnosis right, or at minimum, getting the conceptual framework right, is the prerequisite for effective treatment. Section 6. What effective treatment looks like for each. For anxiety disorders, the gold standard treatment is cognitive behavioral therapy with a structured exposure component, exposure and response prevention for specific phobias and social anxiety, cognitive processing therapy and prolonged exposure for trauma-based anxiety, and a combination of cognitive restructuring, behavioral activation, and graduated exposure for generalized anxiety disorder and panic. DBT, dialectical behavior therapy, contributes powerfully to anxiety treatment through its distress tolerance and emotion regulation modules. Radical acceptance, which we have discussed extensively in this series, is one of the most clinically useful tools for the person with anxiety who is caught in the loop of non-acceptance of their own anxious experience, adding suffering to pain by fighting the fact that the anxiety is present. Mindfulness skills, also central to DBT, help build the observational stance that allows the person to notice anxious thoughts without being commandeered by them. For OCD, the gold standard treatment is exposure and response prevention, ERP, which is a specific application of behavioral principles that is distinct from standard exposure therapy in the ways we have described. ERP involves structured, graduated exposure to the obsessional trigger while deliberately refraining from the compulsive response, with the therapeutic goal of allowing the obsessional distress to rise, peak, and naturally subside without the compulsion, demonstrating to the brain that the distress is tolerable and that the feared outcome does not materialize. Acceptance and commitment therapy, ACT, has substantial and growing evidence for OCD and integrates powerfully with ERP. Where ERP focuses on behavioral disruption of the compulsive cycle, ACT addresses the psychological relationship to the obsessive content, building the capacity to observe intrusive thoughts with diffusion rather than fusion, noticing the thought as a thought rather than treating it as fact, and clarifying values so that the person can choose to engage in life-consistent behavior even while obsessional distress is present. Medication, specifically serotonin reuptake inhibitors at the higher doses used for OCD, has strong empirical support and is often used in combination with ERP, particularly for moderate to severe presentations. The combination of medication and psychotherapy consistently outperforms either alone. And for both conditions, psychoeducation is foundational. Understanding what is happening in your brain, understanding the mechanism by which your responses to distress maintain the very distress you are attempting to escape, understanding that the pattern is not a character flaw, but a learned, reinforced, changeable cycle, this understanding is not just supportive. It is therapeutic. It changes the relationship to the experience. And for many people, it is the beginning of the possibility of something different. The Venn diagram worksheet linked in the description maps all of this comparison visually, the shared features, the divergences, the treatment implications, in one clean, printable reference. It is designed for personal understanding and for therapists using psychoeducation in session. OCD and anxiety share enough surface features that the confusion between them is not only understandable, it is, in many clinical settings, the default. And the consequences of that confusion are not abstract. They are lived, daily, by people who are trying their hardest to get better with a framework that does not fit what is actually happening in their brain. The distinction we have built today, the ego-dystonic quality of obsessions, the compulsion as the maintaining behavior rather than avoidance, the specific way that reassurance and cognitive engagement fuel rather than resolve the OCD cycle, the treatment implications that follow from getting it right, is not complexity for its own sake. It is the precision that makes the difference between years of ineffective treatment and an approach that actually works. If you are a clinician, carry this map into your conceptualization of every anxious client. Ask not just what are they afraid of, but what are they doing with that fear? Is the response a compulsion? Is there an ego-dystonic quality to the feared content? The answers to those questions may change everything about the treatment you offer. If you are someone navigating this yourself, the fact that your intrusive thoughts feel alien to you, the fact that they horrify you, that you would never act on them, that they feel like a betrayal of everything you value, is not evidence that something is wrong with who you are. It may be the most important diagnostic clue of all. OCD attacks the people it inhabits at the level of their deepest values. The horror you feel about the thought is the clearest possible evidence that the thought is not you. The worksheet is in the description. Share this video with someone who has been trying to figure out what they are actually dealing with, because naming it correctly is where healing begins. I'll see you in the next one.